All right, thank you for joining us for today's event where we are going to talk about the targeted probe and educate reviews for cardiac rehab services. My name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education team, and I'm going to be your facilitator for today's event. And I'm also joined by other members of Provider Outreach and Education, namely Jennifer, who is my other nurse, and she's going to be helping with the chat as well as questions and answers for today's event. So my objective for today is that you learn about the essential coverage criteria and documentation requirements to ensure that your services for cardiac rehab are payable by Medicare. And we're going to achieve this today by discussing why this topic was selected for targeted probe and educate reviews. We're going to talk about coverage criteria, and we're going to talk about essential documentation. So let's get started by talking about the targeted probe and educate process itself and why certain topics are chosen for review, as well as certain providers. So why review? We're starting this review this month, actually, because our data analysis supports that cardiac rehab services, specifically in our J8 jurisdiction, that's Indiana and Michigan, pose a risk to the Medicare Trust Fund. CPT 93798, which represents physician or other qualified healthcare professional services for outpatient cardiac rehabilitation with continuous EKG monitoring per session, was the CPT code that was identified. So data analysis then identified cardiac rehab as, again, posing a significant risk to the overall Medicare Trust Fund. And they identified that with the total dollars at risk being above the 99th percentile. And the average paid per claim was above the 50th percentile when compared to all Part B of A services billed in our jurisdiction, especially J8. So there are no cert error issues right now associated with this problem. Sometimes we do targeted probe and educate because it was a cert review. Anyway, further data analysis was performed, and it identified 62 providers that were above the targeted threshold of 516.27 units per provider. Of those 62 providers, we're pursuing 24 providers during the months of April, May, and June. So that's when those targeted probe and educate reviews will be turned on. So based on this data, we'll look at about 20 to 40 claims of those 24 providers, and we're going to look for compliance with the benefit policy manual, namely 100-02, Chapter 15, Section 232. And I'm going to just shove that in the chat really quick in case you are interested, but I believe there's a link to that in the resources page at the end. So how does traditional targeted probe and educate work? All reviews that we start with, we perform data on. So that's how data analysis is done right from the start. So the data analysis is done to see what types of claims that we, WPS, is paying and processing that may pose a risk to the Medicare Trust Fund if they're done inappropriately. So in the case of cardiac rehab, we perform that data analysis and we determined that cardiac rehab services came to the top of those claims that we pay and process, specifically, again, in our J8 jurisdiction. and there is a potential risk to the Medicare trust fund. So from that data analysis, we then drill it down to determine what providers are performing and billing the services to Medicare that fall into that greatest risk category. And that's generally those providers with the highest billing amounts. So after the providers are identified, we then notify the providers of the facilities that we're going to perform a review of their services. So this includes written notification, as well as telephone attempts are made to reach a point of contact at your facility or your provider office. When a targeted probe and educate starts, providers can expect that we're going to review anywhere from 20 to 40 claims, generally on a prepayment basis, so before any Medicare money is given to you. And before your claim, moves on to the payment floor, it actually suspends for review and an ADR is issued. So an additional documentation request is issued, and that notifies you as the provider or the facility that documentation is required to be submitted for medical review. So claims are reviewed as they are received, and a decision is made based on compliance with the regulations. And as providers, you're going to be able to review claim determinations through our provider portal. And you should also be watching your billing to see if claims have moved on to the payment floor or if they denied. If a claim denied, remember that claim denial date starts the clock for any appeals that you wish to submit. So if you find that you are on a targeted probe and educate, don't wait for all 20 to 40 claims to be reviewed to move on to appeals if you have something you're going to appeal, because you could potentially run out of time, and we don't want that to happen. So if you find you get a denial, we encourage you to submit that appeal request, as soon as you can after that denial is made. So in the targeted probe and educate review, providers that are found to be compliant with TPE reviews of their claims will be released from any review and will not be reviewed again for at least 1 year on the same topic. Providers that have denials will also receive one-on-one education with our medical review nursing staff. And I encourage you to participate in that education, even if you have minimal errors found. It's always good to be in the know. So I always encourage our providers, when you're offered, take the education, even if the findings are minimal. So if your denials deem it necessary to complete another round of review, we're going to give you at least 45 days to make any improvements you feel are necessary to show your compliance before we start another round. And providers can be subject to up to 3 rounds of reviews if it's necessary. So if a provider completes 3 rounds and is still found to be non-compliant, that provider, unfortunately, will be referred back to CMS for additional activity. All right, so now that we know why the TPE started, let's move on and talk about what criteria is necessary to support services as medically reasonable and necessary. So cardiac rehab services are physician or non-physician practitioner services that are supervised program that furnishes physician prescribed exercise, cardiac risk factor modifications, psychosocial assessments, and outcome assessments. And I do see, before I move on, there was a question that came in And it says, are you referring to a physician provider or a facility provider? And Sandra, in the case of your question in regards to targeted probe and educate, I mean, it could be either. If you have something more specific, go ahead and drop that into the chat. But when targeted probe and educate is done, it can be done on the Part B side or it can be done on the Part A side. So the Part A side is facility. We could be looking at a facility. And the Part B side is usually when we're looking at a practitioner or a physician on their own. Okay, so moving on with the coverage criteria, let's talk about individualized treatment plans. So part of the criteria for coverage is that each of your patients has to have an individualized treatment plan, and it needs to be tailored to that individual patient and their needs. And some of the things that should be included are a description of the individual's diagnosis. We need to know the type, amount, frequency, and duration of the items and services that they are going to be receiving under your plan of care. Plans should always have goals for that individual, and those goals should be specific to that individual and their individual needs. And of course, you know, the individualized treatment plan needs to be reviewed and signed by your physician every 30 days. So as reviewers, we're going to look for documentation of this individualized treatment plan, and that the treatment plan includes all these required components. And that's in accordance with the 42 CFR 410.49, as well as the Medicare Benefit Policy Manual, Chapter 15, Section 232, which I talked about earlier as well. And I just plopped that Code of Federal Regulations in the chat as well, but it is in the resources slide at the end of the presentation. As with all Medicare services, there are specific criteria that must be met in order for Medicare to cover. This includes specific criteria that is met by the beneficiary and by the facility. So not just anyone can get cardiac rehab services under Medicare, and not just any facility or provider can render these services. So in the next several slides, we're going to take a look at these specific things. First of all, let's start with conditions that qualify for Medicare Part B. So Medicare Part B covers cardiac rehab and intensive cardiac rehab for beneficiaries who've experienced one or more of the following conditions that are listed here. So an acute MI within the preceding 12 months, or myocardial infarction, heart attack, coronary artery bypass surgery, if they have current stable angina pectoralis, heart valve repair replacement, percutaneous transluminal coronary angioplasty, or PTCA, or coronary stenting, heart-lung transplants, if they have stable chronic heart failure, defined as a patient with left ventricular ejection fraction of 35% or less by the New York Heart Association Class 2 to Class 4 symptoms. And that's despite being on optimal heart failure therapy for at least 6 weeks. And then there's some other cardiac conditions as specified in the National Coverage Determination. So the NCD process may also be used to specify non-coverage of cardiac conditions for intensive cardiac rehab if coverage is not supported by clinical evidence. So while the cardiac rehab NCD specifically was retired, there is still an NCD for cardiac rehab programs for chronic heart failure. And that's 100-3, Part 1, Section 20.10.1. And a link to that NCD is located, again, on the resources slide at the end of this presentation. So as reviewers, we're going to look specifically for documentation of a covered condition. And that's, you know, again, in accordance with that CFR and the benefit policy manual. So these are the things that we're going to be looking for. All right. So let's move on and continue with the components to include, because cardiac rehab and intensive cardiac rehab must include some specific components that we're going to talk about on the following slides. So I kind of alluded to this earlier. The first component is physician-prescribed exercises. The documentation must contain evidence of a prescription, a physician-prescribed exercise program. Too many P's in the sentence. Physician-prescribed exercise program. And it needs to cover each day of cardiac rehab items and services that are furnished. So exercise can be aerobic exercise combined with other types of exercises. These exercises are determined to be appropriate for the patient. So as reviewers, again, we are going to look specifically for documentation that supports this physician-prescribed plan. Another condition of coverage for cardiac rehab is there must be evidence to support cardiac risk factor modification. So this includes things like education and counseling and behavioral interventions. On all of these things must be tailored to the individual needs. So let's talk about some examples of risk factor modifications that can be included. So risk factor modifications can include, but is not limited to, lifestyle modifications, like exercise, an exercise designed to reduce cardiac risk, and how to safely engage in that exercise. Nutrition counseling, like focusing on heart-healthy eating, heart-healthy diets, reducing sodium, saturated fat, sugar, increasing fiber. Those are all parts of nutrition counseling. Weight management and body composition, lowering a person's BMI. Those fall into some lifestyle modifications as well, and maintaining a healthy weight and body composition. And furthermore, smoking cessation, because we all know how smoking affects the heart. So if they are a current smoker, how can we get them to stop, and how can we get them to stay stopped? So other risk factor modifications, clinical and medical risk factor management. That includes things like blood pressure management, lipid management, so controlling your cholesterol levels, you know, through diet and any necessary medications. Diabetes and glucose control, because we know diabetes wrecks the heart. And not having good blood glucose control is one of those things that, you know, can destroy a heart easily. So overall medication adherence and educating on the importance of taking their prescribed medications correctly. Another risk factor modification could include things like psychosocial and behavioral changes. How do we better manage our stress? Does the patient need to learn things, again, like information about their medications, taking their medications appropriately, yoga, relaxation exercises, things to reduce anxiety and depression. Behavioral therapy, so programs that use motivational interviewing and cognitive behavioral therapy to assist that patient in making more sustainable lifestyle changes. And finally, mental health support, which could include screenings for and managing anxiety and depression. So remember, documentation's the key here. Whatever risk factor modifications you are working on with your patient, you are teaching your patient, you need to document it so we can see it. So I see Joyce placed an answer in, or a question in the chat, and the question was, will the TPE only be for facilities or providers in the J8 jurisdiction? Right now, Joyce, this targeted probe and educate review is just J8 Part A facilities rendering cardiac rehab services. Now, that doesn't mean as things progress on, as findings come in, that we don't eventually include other jurisdictions, other facilities, etc. But yes, right now it's only facility-based J8A outpatient cardiac rehab. All right. So moving on with our coverage criteria. Another component of coverage criteria is your psychosocial assessment. So this includes your evaluation of the patient's mental and emotional functioning as it relates to that person's individual rehabilitation. So we spoke briefly on the last slide about psychosocial and behavioral changes being part of lifestyle modifications. Here, we're speaking specifically to the psychosocial assessment, which is a core component to identify any mental health barriers so you can improve that patient's participation and adherence with long-term outcomes. So this involves evaluating social support, lifestyle and cognitive function, and is usually done at the start and at the end of rehab to measure improvements. So this could include tools like Psychosocial Risk Factor Survey, or PRFS, Hospital Anxiety and Depression Screening, or the HADS, the psychocardiogram, or the PCG, and that's just to name a few. Those are not limited to only those, but those are a few that we commonly see. So if there are interventions that are needed based on any assessments or assessment tool findings, you need to make sure you are documenting what those interventions are. As we move on, this leads us to outcome assessment. This is the evaluation of progress as it relates to the patient's rehabilitation. So outcome assessment generally contain your evaluation based on your patient-centered outcomes, and it must be measured by the physician or program staff at the beginning and end of the program as well. Evaluations measured by program staff at the beginning and end. So these evaluations actually should be considered by the physician in developing or reviewing that person's individualized treatment plan. So outcome assessments must contain objective clinical measures of exercise performance and self-reported measures of that person's exertion and behavior. Now, one thing I want to tell you with all of these assessments is think in terms of objective and measurable information. Anytime you can document with objective and measurable information, you can give a weight, a length, a percentage. It is only going to behoove you as a clinician to document in that manner, because if I see a 10%, 15%, 20% improvement. I see person was only able to go 5 minutes on speed number 3, and several times later they're able to go 10 minutes on speed number 6. That shows considerable improvement. Things that you want to avoid: patients doing better, patient reports less pain, patient reports better better longevity with walking. Those don't tell us things. If a patient's subjective information says something like that to you, I feel like I'm doing better, then ask some leading questions and quantify that with objective and measurable. That's great that you're feeling better. Tell me about your reduction in pain. Last time you were here, you said you were at a 5 out of 10. How do you feel this time? The patient says 3 out of 10. The patient says, I feel like I'm walking more and walking greater distance. That's great. Last time you told us you could walk a block and then you got winded. How far can you go now? You can go 3 blocks. That's great. Those are things that show us improvement. So I do encourage you to always consider objective and measurable information in all of your documentation. Okay, this leads us to the treatment plan. So treatment plans, again, are those written plans that are tailored to your individual. And this plan should describe the individual's diagnoses as well as the goals that are set under this plan. It should be established, reviewed, and signed by that physician every 30 days, as I mentioned on a previous slide. It should contain the amount, the frequency, and the duration of treatment to be rendered. Remember, cardiac rehab sessions are, under Medicare, limited to a maximum of 2 one-hour sessions per day for up to 36 sessions, up to 36 weeks, with the option for additional 36 sessions over an extended period of time if they are approved by us as the MAC. So even though we're not talking about ICR today, I do want to briefly bring awareness to some coverage criteria for ICR. So ICR sessions, or intensive cardiac rehab sessions, those are limited to 72 hours, up to 6 sessions per day over a period of up to 18 weeks. Remember, to be approved as an ICR program, a program must demonstrate through peer-reviewed, published research that it has accomplished one or more of the following for its patients. So those include positively affected the progress of coronary heart disease, that they reduced the need for coronary bypass surgery, that they reduced the need for percutaneous coronary interventions. So the ICR program must also demonstrate through peer-reviewed, published research that it accomplished a strategically significant reduction in 5 or more of the following measures for patients from their levels before cardiac rehab to after cardiac rehab. And those include your LDL, or low density lipoproteins, triglycerides, BMI, both systolic and diastolic blood pressures, and the need for cholesterol, blood pressure, and diabetes medication. So CMS has a list of ICR approved sites. So remember I said at the beginning of this, there's coverage criteria that affects both facilities and beneficiaries. The beneficiaries have got to have the covered diagnoses, and the facilities have got to be approved facilities. So not everyone can just render or start a cardiac rehab program or an intensive cardiac rehab. And then again, ICRs, you need to go through CMS for that approval. All right, so let's shift gears a bit and talk about the settings. So there are specific settings in which cardiac rehab services are payable. So Medicare Part B pays for cardiac rehab and intensive cardiac rehab in a physician's office or a hospital outpatient setting. So all settings must have a physician or non-physician practitioner immediately available and accessible for Medicare consultations and emergencies at all times when items and services are being furnished under the program. So if cardiac rehab is in session, physician has to be immediately available. So this provision is satisfied if the physician or non-physician practitioner meets all the requirements for direct supervision for physician office services. And those direct supervision requirements can be found in the CFR, and I'm trying to just highlight this so I can throw it into the chat for you, where you can find that information for the supervision requirements. So again, under cardiac rehab, it's direct supervision. All right. And those links to those CFRs are on that slide for you if you are following along in the slide deck. So we've been talking about meeting the guidelines and supporting that you meet the guidelines in your documentation. But let's move on and specifically talk about this documentation and how it's used for review. So as we stated in the coverage criteria, some of the components of documentation that are necessary to help support the services as medically reasonable and necessary and payable under Medicare guidelines include all the things that we've already talked about. So the individualized treatment plan, the physician prescribed exercise program, evidence of cardiac risk factor modification, and psychosocial assessments. So we talked about those previously. But let's move on, talk about a little bit more documentation. Your outcome assessments, which need to be clearly documented and include evidence of those covered conditions like we discussed on slide 10. Those things are needed to be documented, and there needs to be a physician order and physician progress note. And I think we really hit on all of this. Some of the things we didn't talk about are the patient history and physical. This is where we as reviewers are probably going to find the majority of the information about the diagnoses, about the patient's medications, about any other health indications, as well as any comorbidities or complications that your patient may have. Finally, the last component that we have not honed in on specifically yet is evidence of continuous ECG monitoring when it's applicable. So remember, CPT code 93798 represents that physician or other qualified healthcare professional services for outpatient cardiac rehab with continuous ECG monitoring per session. So if there is evidence of continuous ECG monitoring and this CPT code is billed, I should say if there's no evidence of continuing ECG monitoring and we see that it's on your bill, that could result in a denial or a partial payment. So a partial payment could include a down code to the 93797, which is the other code that could be used in this case. So I just warn you to be careful about if it's on the bill, especially if it's that ECG with continuous monitoring, it has to be documented. If we don't see that evidence, then we could either deny or downcode your claim in that case. So that's going to take us to the end of the formal presentation portion of this webinar. So the slide here is just a resources slide, and it contains some helpful resources that we spoke about through the presentation. And some of this information I did put into the chat as well. But here is a link to the WPS resource guide, and I'm going to just pull that up, or the WPS review information, I should call it. And I just want to show you really quick. So it took us to J8 MAC Part A. We're under medical review, and we're under TPE. And I'm just going to go back and show you how to get to this in the absence of the link that is provided. So I'm on J8 MAC Part A. I'm going to go to Topic Center. I'm going to go to Medical Review. I'm going to scroll down here, and I'm going to choose Targeted Probe and Educate. And then I'm going to go to Cardiac Rehabilitation. And here is where we've provided you information about documentation that's necessary, about what types of diagnoses are allowable for cardiac rehab, a little bit about the scope of the review, and some resources for you. So if you lose this presentation, you can always go to our website and look up, you know, the information on what's covered. So let's go back. And at this time, I'm going to look over and see if there is any Q&A that I did not discuss along the way. And it does not look like there is at this time, which doesn't mean you have lost all your chances to submit a question if you have one. Go ahead and type that in the chat, but in the interest of time, I'm going to proceed on, and then I'll stop at the end before I close and see if there's any additional questions. So, all right. One thing we just want you to be aware of, WPS received many overpayment notifications and refund requests from providers. We know you want to repay Medicare in a timely manner. However, there can be delays if you use an incorrect or an outdated form. So missing information or sending checks without explanation are other reasons that can cause a delay. We want to help you to avoid any unnecessary holdups, and we want you to consider using the SecureNet Access portal, the refunds or overpayment claim adjustment features. So this is going to allow for fast and efficient processing of your overpayments and refunds to Medicare. There are times when you're not able to use the online portal feature. Instead, you may choose then to send a paper request for checks. If you do so, we recommend including the correct form, which is available on our website. And I actually did have Jennifer place a link to the article on our website that's going to help you determine which action to use or which form to use. All right. We value your opinion. We want to hear from you on how we did on this event. So there is a survey for this event, and it only takes a few minutes to complete. And that's why I'm going to give it to you now while we're still in session, and you have a few minutes to do it that you've already allotted for listening to this event. It's your opportunity to tell us what additional education you would like in the future as well. Many of our educational events that we provide are a direct result of those requests. So be sure to read all the responses carefully, as the ranking order, you know, may change from what you're used to. Okay, and then I see that something came in, telehealth and cardiac rehab, and I'm not sure what that is referring to. So, Lori, if you want to provide some additional information to that. Oh, is it allowed? That question, I do not know right offhand. So that is something that I will look up and put out in an email to the group. My gut tells me no, but I don't know for sure. And yeah, I'll look up if it's allowed, and if it's allowed, you know, what are the specifics of that. But again, I don't want to say anything I don't know for sure. So I will put that answer out to the group as a whole in the form of an email once I find the answer to that. All right. So finally, if you think of any questions regarding this event, please email those to us at wps.gha.education@wpsic.com and send those within the next week. And that email address is in the notes section of your handout as well. Please don't send any PHI or PII. And remember, we as Provider Outreach and Education, we don't have access to the claims processing system. So if you need to find out something specific on a claim or how a claim processed, you are going to need to pose those questions to customer service. Remember, again, check the notes section of the slide deck for any additional information we want you to know, such as CEUs for this event. So on behalf of Jennifer and myself, as well as Medical Review, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.